Okay, shall we make a start? Hello, my name is Julian. Welcome to you all. This is always my favourite part of the week, which is when we come to see the work that's been happening in relation to the Leeds improvement method. And this week's been very important because we've had, which I think are always some of the most demanding parts, the rapid process improvement workshop for trial without catheter in abdominal medicine surgery, CSU. So thank you all for coming. And I suspect on the front row we've got colleagues who are going to be reporting out, Chris, but I know you've had a very busy week, and it's always a big commitment to make, I know, to actually focus on a patient pathway and the value stream and taking that out when you've all got incredibly busy jobs. But I guess the reflection is, come in guys, have a seat. The only way we're going to take things forward and improve is to give ourselves that dedicated time to do that and to really critically evaluate what we're doing and how we can improve it. And also, the other key part of this is about the patient focus. And come in everyone. Word spreading.
I think urologist just collapsed.
Okay. That's not very reassuring.
Don't worry.
Right. We've got another bus arriving at the front. Just can I say welcome to you all, and welcome to colleagues that are joining us. This is the report out for what you see behind me, and I was just saying how important this is and grateful I am to all of you that have been involved in this. And what's also important is everyone in the whole team and in the home team and everyone who will be benefiting from this gets to hear what colleagues are saying and ensure that we can make the changes that we want to make for the benefit of patients and indeed for the benefit of all of us as staff, because a lot of this is about taking away some of those day-to-day frustrations and things that make life difficult sometimes and improving the way that we work. So that's enough from me. Great to see the team, and please take the stage, and Chris, perhaps you could introduce everyone.
Indeed. Come and join me, guys. Okay, good afternoon everybody. Thank you all for coming. Hello, my name is Chris. I'm a KPO specialist and workshop lead for this week. This is the fourth rapid process improvement workshop in AMS. I keep clicking the slides when I shouldn't be, sorry. Where we focus on the trial without catheter. This is our project form which sets out the scope, what we tried to carry on this week. And basically we set to move the trust goals of providing the best patient safety experience and outcomes. The main target being to make sure that when a patient is discharged from a ward with a catheter, that they come back in a timely manner to the most appropriate place and receive the most appropriate outcome first time. So I'm going to let the team tell you how we went about that this week.
Hello, my name is Sophie, KPO support and team leader for this RPIW. This is our target progress report, which is a tool for measuring improvements we've made a start on this week. During our planning meetings, we chose to measure lead time for the patient being discharged from the ward with a catheter to then arriving at their outpatient appointment. We're measuring working process and standard working process. The qualitative defect we chose to measure was for no unnecessary reinsertion of long-term catheters and most appropriately utilised intermittent self-catheterisation, quite a mouthful. The second quality measure was around trial without catheters being performed in the most appropriate place. Our 5S measure is around the TWOC referral form. This is our tap time, which means we need to meet a demand of 4 patients a day. Jane?
So the starting point for RPIW was demand on the catheter and TWOC service, which was beginning to outstrip capacity both in the nursing perspective and in the environment. So we looked at the number of TWOCs, and they were performed in a number of places by different personnel and with varying results. Once we started looking down a little bit, we found data collection itself was, I guess scanty is the word. The recording of it was poor. So the first determinant really was, where should TWOCs take place? Both in the planning meetings and then as an RPIW team, the unanimous result was they should be in the Paul Sykes Centre. So as part of that, we've developed this like one vision of one place, one time, get it right first time. As we work further down, 3 themes really emerged, and that was coding, referrals, and patient information, but also education and training of staff. So my little team here are going to individually tell you about their role in that process. Mr. Paul.
Thank you very much, Jane. I'm Alan Paul, I'm a urologist in the department here. And as Jane says, I've mostly the issue of coding and our data recording for the TWOCs, and our incapacity to fully record that data reflects a wider issue for us in outpatients in urology. So just as clinicians in normal outpatient clinics, we don't think we're recording properly, and we don't think we're maximising our income and our record of our activity as well as we should. With respect to the TWOC service, especially with Jane's aspiration for all of the TWOC service coming in-house, we're going to need more resource, and we perceive that if we can generate more resource by billing correctly, charging correctly for our current activity, that might let us do that. By way of example, in the last complete month of data we have, which is April of this year, we recorded 46 trials without catheter on paper, there somewhere. But we only recorded 21 electronically, which is, say, a deficit of 25 cases. The TWOC itself costs £280 to the CCG, and if we include an ultrasound scan of the residual urine, which all the patients get at the TWOC, the total unclaimed money we think in April would be £12,500 or so. So we think it's a pretty significant deficit. We identified really only 2 steps in the process of coding, that is to say paper coding by the clinician in the clinic, or by Jane and Crystal, colleagues putting in and taking our catheters. And we don't really have a way of measuring that. We don't know how many people are just not filling in that form, but we suspect it's a number greater than 0, shall we say. And then the form goes to our receptionists in the department, and they code that in the PAS system, and that's where we can measure the deficit. So we've tried to alter the RPO5, the paper version of the form, and we've tried to alter the process as well. David is going to speak about it.
Hello, my name is David Golding, Business Manager for Urology. After identifying problems with the coding, as a team we began to generate ideas. Firstly, greater importance should be placed upon coding. For this staff need a better understanding of the coding process. We have made slight additions to the RTO5 along with the admin process that sits behind it. There was a need for standard work description forms to support our colleagues complete the RTO5s and inputting the outpatient codes on PAS. These forms will work as guides for clinicians, CNST and the outpatient reception staff. Additions to the RTO5 include greater coding options that will give us a better depth of coding. The standard work description form for PAS coding includes safety and quality checks. It will also empower reception staff to return any incomplete forms. The RPIW team will audit the quality of PAS coding and the completed forms at the end of July.
Hello, I'm Nigel, Charge Nurse David Beavers, a member of the RPIW team. Until Paul Sykes Centre gets up and running with a new system, David Beavers during the interim period will continue to take TWOCs from J42 and 43 and our current patients. We have identified problems with the current David Beavers system. There was no accurate PAS or data collection. We did get unexpected arrivals in the unit coming for TWOCs. Patients would arrive with no notes. There was no RTO5 forms for data collection, no TWOC advice booklets linked to patients, and a haphazard system of notifying admin of successful TWOCs, and also no GP notifications. Following this week, we'll identify the system for listing patients for TWATs as soon as possible, ideally post-operative on warding after reading the op notes. Ward 42 and 43 have also been contacted how to refer TWATs via the generic urology booking system, and Ward 42 and 43 are going to verbally inform David Beavers of bookings and send the notes. A TWAT booklet is also going to be given to David Beavers' patients prior to discharge, so they are aware what's going to happen. For TWATs over 48 hours, a leaflet will be added to the appointment letter. Following this, David Beavers' admin will now be aware of listed patients coming in and therefore improve the patient experience. Patients will have an increased understanding due to a TWAT booklet also. And we have also developed a TWAT clinic form, and it is more following standard work and staff education. There's a process in progress to inform the GPs now, and there's a standard work being produced to ensure that RTO5s are completed accurately and coding is informed.
Hello, my name is Crystal and I'm a urologist here in Paul Sykes and team member of this RPIW. Prior to this week, referrals were placed to areas in the hospital that undertakes TWATs in various formats. In David Beavers, this mainly was verbal, and in the Paul Sykes, this ranged from verbal, fax to patient having drop-in visits. An interim email format referral was generated to tackle some of the issues, but this was again not ideal, as it was sent by staff to a personal email address and staff was not always IT savvy. Again, the walk was performed and conversations had with colleagues from other areas. Throughout this process, it became apparent that a great deal of phone calls was fielded regarding TWAT queries and how to place referrals. There are split services available for TWACs, which is either for TWACs to be performed in the Paul Sykes or in the community. However, the community service is not common knowledge to all. Educational needs were highlighted as a problem, as some found the referral forms for areas difficult to access, and some were also uncertain as to which patients should be seen where. On a whole, this could impact on patient experience, as at the end of the day they're sometimes sat around wondering when and where they'll be seen. It was also found that this has led to an increased demand on services provided in the Paul Sykes and had a general impact on waiting times, clinic capacity and staff time sorting queries. These issues were discussed amongst the team and suggestions were made to improve the process. The suggestions were then relayed back to staff on J42 and 43, and they felt that the suggestions would be very beneficial towards service improvement. I'll pass you over to Brooke.
Hello, my name is Brooke. I'm a sister on J42 and team member of this RPIW. After identifying these problems, we decided urology in general needed to be more visible. During this week, we have developed and launched a urology intranet page, started to upload information onto this site. On this intranet page, we have developed a referrals tab. On this referrals tab is a flow chart to guide the user to the correct patient referral, gaining direct access through the click of the tab. See the screen for this process. From this, we then 5S the referral for Paul Sykes Urology and created a new referral which is user-friendly and precise. We started with the aim to create a referral that was easy to save and send to the open CNS email box. However, we knew this was still not the ideal method. The ideal method would have been an e-referral, but we felt within the time constraints this would not be possible. After further discussion, we decided to attempt to create this e-referral, and with help from our IT colleagues, we now have our ideal e-referral, which submits directly from the intranet page to the CNS email box without any need for further email or attachments. This referral will help the user give more precise patient information, meaning the urology CNS team will be able to triage referrals appropriately and more effectively, with the end aim to free up clinic time for new referrals and decrease patient waiting times, which will in the whole provide a better patient experience.
Hello, my name is Emma Wright, clinical educator with the discharge team and team member of this RPIW. So it's already been highlighted that in some areas there are lack of awareness of the cook service in the community, and this resulted in the incorrect referrals of patients to the Paul Sykes Centre and primarily putting unnecessary pressure on our service. There's a useful information tab that's been put on the intranet site, and this will include the cook referral form as well as the referral form for Paul Sykes. And once fully developed, information about what both services deliver and the necessity of referring to the right service. When discussing the patient experience though, earlier in the week, it was described how patients can attend for their TWOC appointments unaware of why they're actually here and what to expect. We uncovered a TWOC booklet that already exists, which explains the full procedure in patient language, how long they can expect to be with us, but most importantly, what will happen if the patient can't pass urine. The use of non-negative language in the booklet was most powerful. Currently, patients are faced with either a past TWOC or a failed TWOC, and the impact on the latter was discussed. The change of terminology to successful and unsuccessful TWOC is also a necessity when thinking about the delivery of good patient experience. Unfortunately, the awareness and use of this booklet was minimal. Therefore, the TWOC information booklet will also be added to the Useful Information tab, as well as the print codes for this booklet provided to all areas across all sites. This is a great resource not only for the patients, but for staff, and especially if staff are working in low-use areas and are unaware themselves of the TWOC process. Obviously, work is needed to embed the new process across all areas of the Trust, and this will be done using Trust comms such as screensavers, Trust emails, but also attending forums such as Patient Care and Safety Day, Matrons and Sisters meetings, the information added to training days, and a ward stomp across the Trust highlighting the need for good patient information. Improving patient information on discharge is needed across all areas of the Trust. Providing the patient with a booklet on discharge and preparing that patient for an appointment in advance is a step forward in improving the patient experience. Providing information on our TWOC services and embedding the new process for also our Trust staff is also an important step forward. And the impact of the education and information provided for both patients and staff is an exciting prospect after only 4 days of working within this team in this project.
So I think I'm going off script now because I think actually this lot deserve a round of applause for the work that's done. An enormous amount of work, and I'm hoping that we've not only improved the coding and improved the referrals, but obviously we've improved the patient experience. It's about the patient experience, but it's also about collaboration with staff. And I think it's testament to the people that are in this room and sat in the audience that we've purposely done as Gemba walks, and we've had to engage with a lot of people. There's a lot of teamwork involved in urology, and a lot of communication and coaching involved, and the people are in the room that we've had to approach, get on site, and create that, sense of change without it being threatening. We know as CNS team, me and Crystal, that we've now got a lot of work to do. This work is only the start, because actually now we need to improve as clinics. So if we have better coding, if we have better referrals, we can then improve as patient pathways so they're not always returning to the hospital. So what me and Crystal really now need to do with our team is to improve our patient experience, not necessarily of coming back, but of having telephone follow-ups. So a lot of our clinics now will be not necessarily Crystal on the phone with that picture in the background. Point it out, it's a job. But I think it is part of that patients don't necessarily always have to come back, but historically we've always done that. So yeah, thanks guys. Thank you. I was going to say, where's my newspaper? So obviously we've now got a list of actions with people responsible for those actions. This newspaper is now live and will keep us on track to ensure that we maintain its outcomes.
So our lead time has a re-measure at day 4 of 13 days, and we have plans in place as described by the team to re-measure at 30, 60 and 90 days. Our first quality measure hasn't changed, as this cannot be measured until the 4 sites' new and improved services up and running, with the additional services and education around ISC. The TWOCs not carried out in Paul sites measure will be re-measured when, as said earlier, this full service is up and running efficiently. The team and sponsors agreed to add in an extra quality measure around clinical coding, which we aim for 100% success in. The baseline for this is 54%, and plans in place as described by the team to eliminate this defect through standard work and empowering our teams. I'm happy to report the re-measure for the 5S referral form is now at a level 3, with an aim to reach level 4 in 30 days.
So I think really the key learnings from this week is run your business, and that's you guys as well in the room. We have efficient coding, plans in place, we can work as a team, we communicate excellently, and we can organise as new ideas, we can plan as change and ensure it's not threatening.
that. So that just leaves me to say thank you. So first of all, thank you to this team. They've been phenomenal to work with, and the amount of work we've got through this week is unbelievable. We couldn't have done that without the home team. Some of you are here for us. Thank you very much. That's both on David Beams and in Paul Sykes. And everybody else listed on there, IT, admin, everybody, we couldn't have done this without you. So thank you very much. Any questions?
So, well done, and I think Jane really summed up, you know, the impacts and the approach. There is an opportunity for any questions or observations from any of you, because I know that this is important work for a lot of people sat here listening to this. So, anything anyone would like to question or add or offer up?
I just think it was really impressive. I used to work with the team a few years ago, and I know how busy it is in that department, and the fact that they've done all that with everything else going on around, I think it is really, you know, it's really something you can be really proud of yourselves.
It's been really hard work. I don't know whether I don't need a nursing home. You know when you just want to sit? No, seriously, I think without the week out though, we couldn't have done it. And I think we wouldn't have done it, or we couldn't have done it, and we haven't done it, have we? Because we haven't had a week out to do it in. And I think that's where it's important.
Yeah.
And I think that's what we've been given in neurology. This is our fourth RPIW.
Yeah.
So we've had 4 weeks where we've been able to take staff out to deliver all these impressive efficiencies that we're doing. You know, and I think that's what the learning is, that you need that time. You know, the stuff you can do, but actually that week is really invaluable to be able to get this work done.
Yeah.
So when I said urology was short, I actually meant it. That's funny, yeah.
I just wondered if there was some shared learning about coding, because obviously you've just looked at one procedure and the fact that our depth of coding isn't great there. What's the learning, I suppose, for other procedures?
I think we haven't just looked at this, you know, so on our current RTO5 there are a number of procedures, some of them relating to the talk service, some of them relating to just a normal clinic appointment and the kind of bedside sort of test we would do. And we don't think we do either of these well enough. It probably should be expanded to include a number of other things, which are some of them less easy to code really. But I think in-house in neurology it touches on a number of things that we haven't done well. And I would hope, just with some of those changes we made, of making it kind of impossible to submit the form or have an acceptable form without ticking something, we hope maybe will change behaviour a little bit. I think in terms of the fullness of the electronic coding, it's about availability of person, it's about capacity. And I think that our receptionists are very pushed, and are particularly pushed at particularly busy times in the clinic, which we can predict absolutely when they are. And if there's only one receptionist doing the booking in and the booking out, it's not going to happen. So if we can take a bit of resource to resource properly that task, which itself is generating resource, I think that was a learning point for me.
I think so the other key to that was, so there was 7 people in the room, half the people in the room didn't know what coding was. So it's this kind of black magic that goes on in the hospital that most of the people don't know anything about, or the importance of. So we talk about communication and sharing that and education. I think that's a huge part of this role, is the importance of coding, because if we don't do it, we don't get paid. It's as simple as that.
I mean, well done. You've obviously done a fantastic job this week, and you know, I'm sure that you will get the clinic set up. I can remember I think it was the second RPIW where we talked about having a Lutz clinic, and now that's up and running, and that's making a big difference. So I'm sure you will shift some of this work into Paul Sykes. My question is, and a comment I suppose at the same time, is each RPIW that I've listened to, people discover things that are already there but not everybody knows about, coding being one of them, the TWOC booklet being another. I suppose, what was your biggest surprise during the week? I always need to say.
Unclaimed money.
Yeah.
An epiphany from here.
We only looked at a couple of months, but when you look at a full year that can equate to, it can be quite scary. Really.
Yeah. And I think, I'm aware of coding and have been since I first graduated, but I wasn't aware that there was a code for talking. So,
And it's not just a code, I think it's a cost associated with that. And part of it is that's fine having a code, but can we know the cost? Because only when you put a figure on it does it actually become real. And certainly that was me, and I suspect, that will be quite an enlightening moment for people really. A simple thing, I don't mean that, but a simple thing like a bladder scan is a couple of £100. Well, a couple of £100 times 5 in every clinic is, it's a holiday for me.
Suzanne, did you have any?
It was similar, just to echo what everybody said. It's just utterly brilliant and really inspirational to hear what you've done. And it was just linking into the coding thing, and you kind of answered it there already. But did you know there was a problem with coding before you went into this, or did you suspect, or was it something?
I think so.
Yeah.
I mean, obviously, I'm relatively new to urology, but I expect there'll be a coding issue across the whole trust everywhere. And just like Jane says, you're performing a swap, there's a bladder scan to go with it, and that's fine.
If you don't tick 2 boxes, you only get paid for one.
Yeah.
And I think we have to look at this previous business manager who actually developed, for us to look at as coding, and that's Gillian sat in front of you, because she first put it on the RTO5. We need to push it further, don't we, I guess, and we've just...
When I came into urology, we weren't getting paid for anything, it turned out.
Charity these days.
Yeah, we were charities though, yeah.
And actually, I don't think it is significantly about the money, but it is also then, you hear stories about the NHS is not efficient. It's actually about recording all the things we do for patients as well, isn't it? And so the activity does relate to money, but there is only so much money in the system, and we don't know whether or not the CCG will necessarily give us more. But at least we are now recording properly what we are doing for patients.
Working efficiently. I think once we start that, we can then change as clinics and make them probably more efficient really for that patient.
And we're also recording it at the right time as well, because I think there was an aspect that was being done retrospectively. It's, doing it backwards, right for the patient.
Jenny?
Yeah, I suppose perhaps reiterate what other people have said about what impressive work you've all done over this week. Maybe when you've had a bit of a chance to reflect, or maybe you can answer now, but what would be really helpful to me would be what is it that would help us to support everywhere, so that there isn't a coding issue anywhere you look. Because obviously from my point of view, working in finance, that's really important.
I would say to empower the person who's doing the electronic coding.
Right.
So, I think what we'd like to do in the debate on the back of the RPIW changes we've made is empower the receptionists. I notice none of them are in the room sadly, but they're probably busy to reject RPIW 5. Whoever has filled in and say, I'm not going to code that, or I'm not going to enter that because you haven't filled it. And unless we allow them to do that and give them space to work, then we're never really going to know what we do. But I think to empower that relatively junior person in the team is the only way I can see that.
I think coding needs to be brought up or be part of induction. I think, like Chris said, of the 7 of us, there was only a couple of us that knew what coding was and how we get paid. And it doesn't need to be really in depth at induction, but just a small section on coding and how the hospital gets paid for an outpatient appointment, something like that.
Just in terms of what Anne's saying, I think we can share some learning here from what Chapelhouse have done in terms of rejecting paperwork being generated by the consultant body because it's incomplete or illegible. They've gone through that process, so we can fairly easily replicate what's happening.
And the consultants didn't eat them, and they did fill in the forms better.
I was going to say, I think if we do it in context like sites where we all know each other and we know the reception very well,
Yeah.
You
I mean, I
nobody has
think
to
in
feel
the
threatened
States,
by that, do they?
no, in the States they don't call it coding, they call it billing. And you know, maybe we
Not
actually
2
have
miles
to
from here, I call it billing as well.
Absolutely. Okay. Finally, Helen.
I couldn't let this week pass without congratulating Sophie. Sophie joined the KPO team in December 2015, was it, Sophie? Partway through her business admin apprentice programme, she's completed the Lean for Leaders programme. We were celebrating Lean for Leaders before you all came in the room. This is what you can do at the end of Lean for Leaders. You can get involved and support this work. But Sophie's done an amazing job this week and is a credit to the KPO team.
Can I add to that? Because there's, me and Sophie are the only two that cry.
Well, on that note, what I wanted to do was award all of you involved with your certificate of participation. So, Jane, Alan,
Thank you.
David, well done. Nigel, well done. Crystal, Brooke, and Emma, and I think Nick, we get a photo of us, but I think just to recognise all of you, what you've said, and I think how you've presented and talked about your experience. This is important to remember. This is the start and not the end. This is the beginning of what we hope will be sort of transformation of the way the service operates. There's loads in this that you kind of, you know, with light bulbs going off in I'm sure inside all of our heads about how we can further develop. You will have the opportunity to come back and tell us after 30 days, and then 60 days, and then 90 days. So we want to keep track of how it's going, and it was encouraging to see, Jane, already the newspaper, quite a bit of that complete, so you're off to a good start.
My team is not me.
So well done, and many thanks for all of you for coming. So I think from the point of view of everyone's efforts, I think another round of applause. Come together, we'll get a quick photograph.